Great. So good morning, afternoon, or evening, depending on where you're watching from. Thank you all for taking the time to join us today. I would like to introduce you to our presenters. We have with us Dr. Jeremy DeWall, who is the EMS Medical Director for UC Health Center for EMS Excellence in Colorado, and James Mclaughlin, Director of Community Paramedicine at UPass Regional Health Service District, also in Colorado. Thank you both so much for being here. To start, I would like to hand it off to Dr. DeWall for an overview of your service area, agencies, and hospitals.
Thank you, Karen. Thank you to all of you attending. I'd like to talk a little bit about where we are and some of the general geographic and healthcare systems within the area to give everybody a good idea of where we're working, what we're talking about, and where we're trying to go with this. We are in kind of central Colorado in the Front Range and into the mountains. Basically, we cover primarily the area of Teller County, as well as portions of western El Paso County, just west of the Colorado Springs area, and also portions of Douglas and Park County with this program. We cover about 1,800 square miles, which do include urban areas such as the city of Manitou Springs and the city of Woodland Park, amongst other smaller cities, as well as rural areas and certainly frontier areas with transport times of up to numerous hours for our EMS transports.
My name is James Mclaughlin, and I am the Director of Community Paramedicine with UPass Regional Health Service District. We, again, cover a portion of that 1,800 miles. We cover 539 square miles in portions of Park, Teller, Douglas, and El Paso counties. And we do this with telehealth being one of the tools that we utilize. We also have a pretty robust behavioral health program, and we provide additional social and support services in partnership with our local critical access hospital, our public health department, and our Department of Human Resources, as well as a variety of other community partners.
So the service area that we cover is approximately 36,000 patients. As you can see, we have a combined area, which is the Colorado Springs metropolitan area and extending out into our mountainous regions of approximately 1 million people dispersed across the urban, rural, and frontier areas. But the particular service area we're talking about is essentially 36,000 of those particular potential patients. So within the particular area that we've developed this telehealth program, it includes numerous volunteer fire and EMS agencies, including volunteer non-transport agencies, as well as a volunteer BLS transport agency, which is in southeastern Park County and has transport times usually of an hour and a half up to 2.5 plus hours, depending where they're transporting into, typically into the Colorado Springs area for the hospitals. It also includes 2 advanced life support transport agencies, one in the northern part of Teller County that services that area in the parts of El Paso, Douglas, and Park County, of which is James's area, UPass Regional Health Service District. And then we have a colleague agency, Southwest Teller County EMS, which covers primarily the southern part of Teller County and also helps with ALS response into southeastern Park County. We do have community paramedicine, which is primarily based out of UPass Regional Health Service District, which does service the entire area that their service district is, and also does help out with community paramedicine and behavioral health in the adjacent areas with the adjacent agencies. We also include an agency within our telehealth program that is Manitou Springs area and is a hybrid fire and EMS department that is made up of both volunteer as well as paid providers within that agency. So with our hospitals and healthcare facilities within the area, we have 7 facilities, including a level 1 trauma center, a level 2 trauma center, multiple other hospitals and specialty hospitals, including women's care, pediatrics. We do have a newer children's hospital in the Colorado Springs area. And then we do have 1 critical access hospital, which is Pikes Peak Regional Hospital. Pikes Peak Regional Hospital is the only hospital truly within our EMS service area that we provide telehealth, and that is within the city of Woodland Park, which is in a mountainous area at approximately 8,700 feet altitude and is approximately 20 to 25 minutes from our level 1 and level 2 trauma centers that are centered in the downtown area of Colorado Springs. So with our critical access hospital, Pikes Peak Regional, they do have fairly decent services. They do have a 24/7 emergency department with board certified emergency medicine physicians. Also has full radiologic capability, CT, plain film radiography, MRI scanner on a limited basis. The ER is approximately 9 beds and the inpatient unit's approximately 12 beds. There is no critical care inpatient ability. So those patients are frequently transferred down to the Colorado Springs metro area for further care and admission if needed. Pikes Peak Regional Hospital is a trauma center, but it is obviously not a level 1 or level 2. It's a level 4 trauma center within the area. So it does have some limited trauma capabilities. So that's basically the area that we cover in service to help people understand as they're comparing this to their local service areas. But as we're going to talk about through this, there's real ability of using telehealth to help with healthcare disparity and access to care and navigating the healthcare system, both in rural, urban, and frontier areas throughout what we believe the United States and other areas internationally.
All right, thank you, Dr. Dewall. I know you've been working in this area for around 12 years, and James, you for around 14 years, and you both recognize the need for something better. James, what were some of the biggest challenges you faced that led you to set up a new way of doing things, particularly employing a telehealth system?
Yeah, so in the region that we serve, it's a very mountainous area, and it tends to be extremely geographically isolated. So we have large populations that have been marginalized just because of their inability to access care. So we have, patients who need primary care, patients who need behavioral health services, patients who need, specialty care. And they really struggle with accessing that care because there's just not enough providers to provide the care in those areas, first of all. And then the other problem is people have a hard time getting rides and accessing those, especially when we start talking about our marginalized populations, like our elderly populations where they don't drive. And our average lot size for somebody who owns or rents a residency in our area is about 5 acres. And a lot of these folks tend to live in those areas for a reason. And so they don't have obviously we're generalizing here, but a lot of them don't have a very robust social support system to help guide them and provide them with services. And we had established this program initially to kind of address some of those disparities. And then as COVID-19 kicked off, and we really started to see an increase in the fear across the country, but in our community, we saw people that were just terrified to go to the hospital. And we saw people that were literally dying because they were afraid to access the care that they need. And honestly, a lot of people couldn't access care with their primary care providers. So that care would go that need for care would go unmet. And so we really identified, we had this program, we were starting to use it in other areas, and we got together and decided, like, this is the tool that will help us increase the services that we provide to patients. And we even saw, as I think we did across the country, but in our area, we even saw the number of people calling 911 significantly decrease. And so that was a major concern for us. And so what we did is we wanted to keep our providers safe, but also increase the value that we provide to the service and to the community. So with Pulsara, we were able to put an app together that allowed us to send a link to a patient before we ever arrived on scene, and actually start that communication process before we ever made contact with the patient. And then once we made contact with the patient, we were able to then link with our primary care providers and the groups that we work with, so that the patient could have direct access to care through that network.
Great. And Dr. Dewall, question for you. What exactly is this telehealth system all about, and why did you choose it over utilizing existing communication methods such as your faxes, radios, and pagers?
Well, and I think James hit on a bit of that, but really when we were looking at this in COVID-19, as James mentioned, the issue really was a bit about COVID, but more so it really melded very quickly into patients being afraid to just go to an emergency department because they're worried they're going to contract COVID-19. Or as James mentioned, fearful of actually accessing the healthcare system, or quite frankly, not being able to access it, because if you had a cough or a cold or a sore toe or anything, you essentially were told by the primary care physicians, we can't see you because we can't risk getting COVID ourselves. So it really restricted access to our patients. When we look, our patients have about 14% of our patients in our area, when we look at our telehealth data, don't have a primary care physician, which means 86% of our patients do have a primary care physician. And yet we still see utilization of telehealth, probably because they can't get into their local primary care physician. And that's a problem in urban areas as well as rural and frontier areas. I think throughout the United States, there's lack of ability to get in, even if you have a primary care doc. So what we looked at with this was, how can we get a physician working with community paramedicine or other EMS providers directly to the patient? And honestly, when we started out in COVID, we had no idea what to use. We looked at multiple platforms. We even looked at WhatsApp because we did have some state allowances and waivers to be able to actually utilize what otherwise would be very not allowed systems to try to access patients in the middle of the COVID-19 pandemic. Obviously, we decided that was probably not the best choice and really tried to pursue what would work. The reason we ended up settling with Pulsara is, quite frankly, it's known to EMS within our region collectively, of that whole area that encompasses that 1 million plus people. That particular area, all of our EMS services for numerous years have used Pulsara to improve our STEMI, our stroke care, our hospital communications. So it was pretty simple. When we started looking at other platforms and trying to figure out what would work, we found that something that EMS consistently used in daily operations was likely to work best in these new environments and in the middle of a pandemic when providers are burnt out. And as our providers have said, we never spent so much time learning stuff to not respond to calls. So we really looked at that and said, how can we best roll something out without burning out our EMS clinicians? And that's why we went with it. And it allows us video communication. It allows us all these different methods. Now, when we looked at Pulsara, they didn't actually have the ability to do this yet. We approached them because we were using them for other uses and said, we have a goofy idea. We need video telehealth and we need it today. The answer was, we can't give you it today, but we can work on it. And within a month, we actually had a platform that was the initial one and really has melded to what we have today and what we're using in numerous areas. The original spot was Pass Regional Health Service District. We've expanded it to other areas or other agencies, as we talked about, and likely expanding further in the future.
Great. James, how did your patients feel about this new telehealth program? Was there much resistance or did they embrace it?
I love this question because I was very concerned at first. We do have a large population that's, geriatric. We have a large population that's anti-technology, and I really was concerned that there was going to be some pushback on adopting this product. And I think there would have been if it didn't just instantly work so effectively and so well. And that's the one thing, I will be honest, I was an initial naysayer of the technology, and I wasn't convinced that this was going to be the answer for our needs. I was probably one of the loudest people against adopting the Pulsara technology. I felt it was going to increase the workload for our providers and put a lot of extra work on them. And what I've been absolutely mesmerized by is the fact that it just works. The user interface works exactly like you would expect it to. Every button does exactly what you would expect it to. And that's what our end users see as well. So when our providers are out there and they're especially early on when we first adopted the telehealth process, they have a lot of new skills and abilities that they're implementing. And what's great about this is it doesn't task saturate them, because it's a product that they're already familiar with. That's so intuitive, and our patients have the exact same experience. They're just First of all, let's remember back to the COVID times when it was first ramping up. People were terrified. They were scared. They were scared to reach out to help. And when they did reach out for help, it was generally because they had no other choice. And so when they turned to us and they saw that we were attentive to their concerns and their fears, and we had developed a technology that addresses those fears and increases their access to care, I can tell you that they embraced it instantly. And I can't tell you how awesome it feels to be at a farmer's market or in a grocery store and have somebody walk up to us today and literally, without asking, just come up and give you a big hug and say, thank you so much. Your team, they really, they helped me, they helped my husband, they helped my father, they helped my mother. And it wouldn't have been possible without that. And we do track satisfaction scores. That's one of the things that we do. And what I can tell you is that on a scale of 1 to 5, where 5 indicates absolutely excellent service, what we're seeing is an average of 4.6 out of 5 on our satisfaction score. And that just tells me that patients are relieved that we've added value to the services that we provide to them. And that makes me feel great, and that makes my whole team feel great because we feel like we're hitting the mark.
And I think one of the really interesting things that we found too is as James mentioned, we track a lot of data on this because it's a novel program. It was one of the first in the state to start. Obviously, we started at a difficult time. And we had a student out of the University of Phoenix Medical School who was wanted to do a quality management project in emergency medicine or EMS. So she actually went through and pulled our initial data, which was our 2020 to 2021 data, right in the beginning of the program. And she reached out to as many of the patients or families as she possibly could through this study and reviewed that information through our quality management side, and actually found that in general, patients within our communities, both urban into rural and frontier areas, don't like telehealth. They don't like the telehealth that comes with their insurance plan. They don't like the free one where you get the doc in a box that comes on and asks them a couple questions and usually says you should see your doctor, or you should go to the ER, or you should go to an urgent care. And they really felt limited within the communities, is what we were hearing through what this medical student found out. They like this system because there was someone there with them. There was an EMS clinician present with them, whether it's a community paramedic, an EMT, a paramedic, that's touching them and listening to them and feeling them and communicating with a local physician that understood their community, that understood their needs, that understand their difficulties. And that made them comfortable, where they actually really liked this system and actually said they liked it at least as much as going to the ER. And typically about 80% said they liked it better than going to the ER, obviously, because it's quick, is probably the biggest reason. So that's really what we saw. And it was cool to see the data coming from the medical student looking at that, and why was there that difference, because we didn't know the answer until she found it for us.
Yeah, that's great that you were able to have her look into that. Both of you kind of touched on this a little bit already, but Dr. Dwal, what about the fire and EMS teams? I know they have been using Pulsara for EMS to ED communication. How was integrating this new telehealth functionality into their existing workflows?
It wasn't without hiccups, because everything new has hiccups. And quite frankly, it was us trying to figure out from a leadership perspective, from having leaders like James, as well as other agency leaders, really grasp it. That was, I think, our biggest challenge. Was this was completely new to EMS. And how do people understand it? That was the challenge. So we actually ended up developing a bunch of short videos on how to use it, giving examples. And quite frankly, what we started with is not what we do now. Some of it is, we've continued to improve it, both on the physician side, giving them feedback on the EMS clinician side and agency side, as well as on the technology side, working collaboratively as a team, saying what's working, what's not working, how do we improve this as a team, which has been really wonderful. So that was the challenge, is initially getting the buy-in. And I can tell you, we don't have full buy-in in all organizations that are doing it yet, because with James's team with UPass Regional Health Service District, they were the first ones. We have great buy-in. We have a very robust system to support it. And some of the other agencies, it's still that challenge of, I can have the patient sign a release of care, and I can say adios, get that signed real quick, leave, and that's it. And that takes less time. Obviously, it takes less time to do telehealth than transporting a patient, as we can hit on later. But it's certainly, telehealth takes more time than sign on the line and good luck with your life, which is honestly what traditional EMS is, right? That if we did release a care, we'd quickly talk to them about risks, benefits, and alternatives. We'd sign a piece of paper, we'd leave, we go do our PCR and move on. What has taken that time is to help our providers understand there's more to this. We're really helping patients in their homes. We're really helping them navigate the healthcare system. And we're hopefully decreasing poor outcomes for those patients in the future, which I truly think we are based on our data.
And Jeremy, I can't agree with you more. I think you absolutely hit one of the pinnacles of starting a new program. You just don't know what you don't know, right? And there's so much. You have a vision of how it should go, and you have a vision of where things should go, but you have to be flexible, and you have to have an amazing partnership. And I will say, we have an amazing partnership. You have to have that willingness to have those difficult conversations and say, hey, look, this isn't quite working. And then you have to have the bravery to, to pull something and change it. And the important other piece to that is you have to have a partner who's willing to pivot with you on a dime. And that's what we've seen with Pulsara, is that when we have an issue, and we say, hey, look, guys, I know we asked you to, put time, effort, and energy into building this piece, or putting that button in, or putting that space to put information in, but now we need it to, we need it not only to collect the information, but we need it to push into our EPCR, or we need the ability to sign something, or we need the ability to add labs. And every time we came to them with an ask, they understood the importance of what was happening in our community and the importance of the need. And they really were incredibly responsive. And our crews saw that. And when you have a partner like that, it really allows you to not waste your time, effort, and energy on coming up with alternative ways to do something. You can just get it to do what you need it to do. And that allows you to pour your research and development energy into advancing the next piece, or addressing the next quality assurance measure that needs to be addressed.
And I think what we found is that we initially thought, oh boy, this should only be community paramedics doing this. And James and I were both on that. This is going to take a lot of effort. It's going to be difficult, but because it was utilized throughout our different agencies for different uses with notifying emergency departments, et cetera, we were able to find, and what we have now is we have BLS providers at volunteer transport agencies utilizing it. We have the ability for BLS volunteers at non-transport agencies, as well as ALS folks, to do that on both sides, the volunteer and paid. So I think that's made that's been a huge enlightenment to us, is that telehealth doesn't have to just be the transport agency. We can use it in multiple different ways.
Well, and as the transport agency, it's a force multiplier for us, because these BLS transporting agencies, if they're not sure, their go-to is to reach out to us and request mutual aid from us. And we're not always the answer that the patient needs, honestly. And so it empowers those agencies to build a stronger partnership with the physicians group, and to actually be the answer for the needs in their community. And it allows us to keep our resources in our community and serve our community. So it's a win-win for everyone.
Yeah, and I'm glad you brought that up, Jane. So obviously the daily operations of a program like this are extremely important, as well as its sustainability. James, where did you get your doctors to be a part of this program? And why did you end up using EMS and emergency medicine docs instead of family practice or internal medicine MDs?
I'm so glad I have an opportunity to talk about this, because picking the right partners is imperative to any project or program that you bring to fruition, right? If you select the wrong people, it's going to be really hard to make it successful. So we reached out to a lot of different partners, and we reached out to a lot of different physicians groups. And at first, most of them had not the time, effort, or energy to even entertain the conversation, so that we could share our vision and our idea. And of the few that did, they didn't bring to the table the collaborative partnership that we desired, right? The doctors don't have all the answers, and the EMS providers don't have all the answers. It's when we come together and we work in a meaningful way as a team and communicate in an effective manner as a team that we really accomplish great things. And what was so awesome is the answer was right in front of our face. We had an amazing group of physicians that we worked with at the local emergency rooms. They knew us, we knew them, they knew each of our providers' strengths and weaknesses, and we knew the nuances associated with those physicians. We already had a relationship, and they saw our vision and understood what we were looking to accomplish, and they made our vision their vision from the beginning. And it is really hard to find a partner that's willing to do that. So when we had those initial conversations with George Herpner and the group from EMSPC, and they heard the passion that we had to truly serve our community, it aligned with the passion they had to serve our community. So it was a perfect fit from the beginning, and they were willing to step up. And I'll be honest with you, they are not covering the cost of the program at this point. They're still not not covering 100% of what they're putting into it. And yet the physicians continue to show up. They continue to fill those shifts. They continue to be available. And we're getting there. We're getting close. And I know that we'll be there soon. And they know that too. But it hasn't come without some pain, right? But we did look at other groups. We looked at using non-emergency physicians. And the reality is when you use board certified emergency physicians, they understand what the ER can do and what the ER isn't equipped for. They understand kind of the rules and regulations around EMS. And so they're not going to put our agency or our providers in a position where they're going to be asked to do things or co-sign things that just aren't safe for the patient. And so that collaborative partnership and that understanding of one another's worlds has added so much value to the work that we do. And honestly, this collaborative relationship has made the relationship even stronger in the ERs, because now we come in and we see each other and we remember that amazing work we did for this patient who, couldn't get the medications that they needed, or the behavioral health patient who was getting ready to run out of their their behavioral health medication, and they were terrified and they were scared, they had nowhere to turn, and they couldn't get a hold of their physician. And so they reached out to us as a last ditch effort, and we team up with our physician, and they were able to make that happen. It is not an exaggeration to say that this partnership changes lives. And I don't know that we would have seen that with another partnership.
Yeah, and there was a patient satisfier as well, correct? With the physicians actually being in state.
Absolutely. And that's a fantastic point. There are other programs that use out-of-state physicians. And again, you just don't understand, right? You don't get that same value when you're working with a physician who doesn't know the nuances of your state, the resources that are available. Colorado has unique challenges, like California has unique challenges, like Florida has unique challenges. And if that's all that's available, I think that's better than nothing. But if you can bring an in-state partner like we have here, I think there's real value to that.
Well, and Kara, I'd like to add to that too, because I know there's parts of the United States that there's agencies we've heard from them that are really trying to develop a program, and they don't have any local partners that are willing or interested in doing it or able to do it, quite frankly, especially in some of these rural areas throughout America. You may not have an emergency medicine group that's close to you, or even in state that is looking at doing this. And I think the key, in-state's helpful, but I really think the magic that we've seen in looking at a program and how to develop this into the future is that more than in-state, you need a physician partner group, whatever it is, that is willing to come and learn about your area.
Yeah.
So for example, right now today, the same people that work with us, with our agencies, are on the other side of the state, actually working with another agency, developing their telehealth program. And that agency's chosen to do that for that exact reason. They actually have a doctor out there who's learning about their challenges, their needs, their wants, how their community is set up, what their resources are. So I think that's the key, more than even the in-state versus out-of-state, is finding a partner who is willing to meet you and learn about you. And as James mentioned earlier, have those challenging conversations when they need to happen. And then bringing that back to the rest of the team that's doing the telehealth, so that it does seem like to the patient, regardless of where the docs are, regardless of those components, that when you're on together, it's you together working with that patient as a team to develop their care plan collaboratively. That's what I think is the magic in it.
Yeah,
I so agree. And I absolutely agree with that.
that's a great point. Dr. DeWall, how is this different from calling med control on the radio?
Yeah, very different. Number one, there's video. If there's not video, if you're in an area that we've had really good luck in the mountainous areas and where we have very limited service. It works through cellular. We have cradle points on our ambulances. It works through people's Wi-Fi. It's all a cloud-based type of protected program, so we can use public Wi-Fi if we need to. So it works well, but I mean, 99.9% of the time we can do full video. It works fine. There's always an option to do audio only if you need to, or usually if the doc turns their video off, it works in those very, very rare instances that we've seen. So we've had pretty good luck with that, where I can tell you our radio function in some parts of our region is worse than that, which is pretty surprising. James is shaking his head yes on that one. And that's been one of our challenges. So I think we've seen that. Now, interestingly, in the city of Colorado Springs, they do use the same platform to do actual med control, where they'll call one of the medical directors and talk to them directly and say, hey, can you take a look at this EKG? Or, hey, we have this patient, and they'll utilize it that way, but they're not doing it for full telehealth. They're doing it just as a quick, can you answer this question for us? So you can use it for medical control that way, but this is truly to be all encompassing and provide a full care plan for the patient where they don't need to go to another destination.
Yeah, and if I may add to that just for a second, the other piece that's really powerful about this platform is it integrates with so many other parts of our system. We're able to, for example, we have the Tempest Pros on all of our vehicles, and we are actually able to integrate the data that comes from Tempest Pro through Continuum directly into Pulsara. So the physicians are able to see EKGs and vital signs in real time. And that's an absolutely, I mean, I've never heard of that before. And all of the information is sent through a 250-bit end-to-end encrypted format. So my patient's information is going to be kept confidential, and there is absolutely no way for somebody to erroneously gather that information.
Yeah, that's a great point. Dr. DeWall, during time-sensitive emergencies or even the routine case, how has utilizing Pulsara helped you and the crews save time? Has it had an effect on time management?
Yeah, it definitely has. And as I talked about briefly before, obviously it takes longer than doing a release of care or refusal, as it's called in other areas. But really, when we look at transport times, and there's evidence out there, there's studies out there people can look up that show both urban as well as rural based, there's a significant time savings for time on task with using telehealth in a system that's used it. Initially, yeah, it takes a little more time to learn it and to grease the wheels on the system. But once you get it going, it's very, very efficient. So in some of our areas, especially in rural areas where we have transport times of an hour and a half to the hospital and a return time to the service area of relatively similar, we can do a telehealth call and be in and out of that patient's home in 20 minutes, sometimes less, sometimes a little more, compared to a 3-hour time on task transporting a patient to a hospital, or if they're ET3 service to an alternative destination, etc. So there's definite time savings with it, with being able to care for that patient. The other part is a lot of release of cares, as we all know, end up utilizing the healthcare system in another way, going to an urgent care, tying up an urgent care or an ER bed, or reutilizing 911 in the near future when they get sicker. And we found that this has decreased that return utilization rate as well, so that we're saving time in the long run, not having to go back out and run on those patients a second time.
And James, how does this turn your emergency responder teams into force multipliers? What do you mean by this?
Yeah, so I mean, it's no secret that in our system and in systems across the country, we're seeing the number of Medicare, Medicaid, and private pay patients increase, right? For our system, it was 80% of all of our calls were, the payer of the identified payer was Medicare, Medicaid, or private pay. And those don't cover the cost of providing care. So you're losing money every single time you transport one of those patients. But those patients need care and they deserve the same level of service as everyone else. And so what our reality was is we had 3 ambulances, and there was no additional funding that was coming down the pipe or was going to be available to sustain increasing staffing from 3 ambulances to 4 ambulances to 5 ambulances. And really where we were at with our call volume at the inception of this program was we probably needed 5 ambulances if we were going to use a traditional model of transport everybody to the hospital. And that just, first of all, it didn't provide good value for our customers. And second of all, there was no money to sustain that. So it wasn't a model that we really had any interest in pursuing. And we felt like this model, and what's proven to be true for that, is that this model allows us to do more with less. And so we still have our 3 ambulances and they're available, but now the community paramedic can go out as a single resource, do evaluations, provide assessment, do care, and keep that patient where they really want to be, at home, and get them the services that they need and get them connected with the ongoing care. And my ambulances are still in service, still available for those life-threatening emergency calls for those patients that absolutely do need to go to the emergency room. So, and a force multiplier is just that. It's a way to take your existing workforce and multiply what it's able to do and add value to your community. And especially if you're a tax-based entity, if you're not doing that, if you're not the value option for your community, somebody else is going to come in and figure out the formula and do it. And it's probably going to impact your ability to continue doing the service that you do. So I would encourage anybody out there who is looking for a way to be the value option for their community is to find the way that you can be the force multiplier with your existing resources.
Thanks, James. Dr. DeWall, how has this new program helped make fire and EMS a more integral part of the patient care continuum?
Yeah, really integrating fire and EMS at all levels of EMS provider, EMT, up through paramedic, critical care paramedic, community paramedic. It's allowed them to interface better by working with emergency medicine physicians, and by both sides, as James said on earlier, being able to communicate better together and more effectively. And one thing we hear consistently from our providers who utilize telehealth is that they're actually learning. Each call, they learn more about how the physician from emergency medicine acute care side is thinking about the patient, different assessment techniques, different questions to ask that not only helps within telehealth, but helps on their day-to-day care of patients. The other thing that it really helps with is allowing those providers, as they age in fire and EMS, to potentially move into a community paramedic role or another role that isn't as taxing on their body, quite frankly, and gives them that opportunity so they can stay in the healthcare continuum for a longer period of time.
Good point. And James, I know you all have been able to work with public health to develop programs as well, correct?
Yeah, it's so amazing. When we first approached public health with our vision, the person in charge, her name was Martha Hubbard, and she absolutely had a love for the community and for serving the community in the public health role. And they had so much they were being asked to do in a rural community and such limited resources. And so we, from the very beginning, started working together to see if we could find ways to be a force multiplier for them, to add value to the services that they provide. Because the one thing that's true about our community paramedic program is that our goal is not to be the answer for everything. Our goal is to know who the partners are that are available in the community, and then empower patients and empower clients to access those services. And our partnership with public health has been just a perfect example of that. And then the transition from Martha Hubbard retiring, and then our new community public health worker, Michelle Wolf, stepping in, has seen that role grow even more. They've partnered with us. We were, because of their belief in what we were doing, we became the only provider in our community that was doing monoclonal antibodies. But more importantly, or as importantly, recently, we've teamed up with them to identify geriatric patients that are geographically isolated, who are alone. And we know that that loneliness and isolation is a real public health emergency in many communities across the country today. Elderly folks feel marginalized because they just don't have access to resources, and they don't have access to interaction and socialization. And so under this program, the GOLD program, which is geriatrics leading to opportunities for increased dignity, it's all about teaming up with Teller County Public Health and Teller County Department of Human Services, and identifying what those barriers are for them accessing socialization and care, and then teaming up with those partners to increase that access. And I'm real excited to see where that program heads.
Yeah, and you're kind of touching on this next. So how does this system help address healthcare disparities in both urban and rural contexts?
Yeah, and that's a fantastic question. And like you said, I did start talking about that already a bit. And that's we're not going to be the answer to everything. EMS was never designed to be the answer for everything. But our healthcare system in America today has gotten so complicated and so difficult that, so many times the door is slammed in the face of patients, and they find the wrong door, quote unquote, to accessing care. And our approach is, there is no wrong door. We're the easy button. If you don't know, reach out to us, and we will help you. We will empower you as the patient to understand, what options are available for you, and then provide you with contact or resources to get set up with those services. And then we're going to follow up with you and make sure that, that connection happened. So we're not doing just what we call a soft handoff, where it's, hey, here's a bunch of resources. Good luck with everything. I hope everything works out for you. We're actually going to make that initial call in your presence, or empower you to make that initial call so that you can set up that appointment. And then we're going to make sure you have a ride. And again, we're not always the answer for that ride. We have tons of community partners that have the ability to provide rides. And so we're going to set you up with that and help you make contact with them to make sure that, that can happen. Because the goal isn't to just address the immediate problem. The goal is to empower you to better navigate this incredibly complicated healthcare system. And my hope is, by the time we part ways, you have a greater understanding of the healthcare system, and you have greater healthcare literacy.
And in an urban area, it's useful as well, correct? You all have been able to use it for like your neonatal patients.
Yeah. Oh, and thank you for bringing that up. It's absolutely true. So one of the things we struggle with is when newborns are released from the hospital. The hospitals that deal, or that address, labor and delivery and newborns, they're all down at 6,000 feet. Well, our district sits between 8,000 and 10,000 feet. And so a little newborn that's doing fine at 6,000 feet isn't always doing well at 8,000 to 10,000 feet. And so when they come up, they're instructed to stop by, and one of our providers will do a pulse ox check. Well, the part that had never historically been addressed is, what do you do with this fragile, susceptible newborn who is hypoxic? Well, the easy button had always been, load them up in the ambulance, the most expensive form of transport, and take them to the emergency room, the most expensive destination, and expose this vulnerable person to all the illness and disease that's in the emergency room when they're so susceptible. So obviously not a great answer. And so what we've been able to do, and what this program has allowed us to do, is if we identify a patient who's hypoxic and newborn, and there's no other signs of distress, no signs consistent with pneumonia or anything like that, then we can do that full head to toe assessment in front of the physician. We can talk with the family, and then the doctor can actually order the oxygen for them. And we are able to bring an oxygen concentrator to their home and get them set up on the initial oxygen, because it's going to take, honestly, in our area, about 2 weeks for, even in our urban settings, it's going to take about 2 weeks for an oxygen company to get up there and deliver oxygen. So we can get that temporary oxygen concentrator to them, get that program going, and get them set up just as a bridge to the gap in healthcare. And then they can follow up with their primary care physician, and that primary care physician can provide the ongoing care. So it's a collaborative partnership that really increases access to care and addresses some of those disparities that we see in the healthcare system.
Yeah, and you're kind of already hitting on this subject, but how does this new system bring back and modernize the traditional house call?
Yeah, great question. It's so, and that's really how we see it. We all remember those old TV shows, or if you've read any books, Little House on the Prairie and things like that. The doctor used to show up and you paid him an apple pie, right? And obviously a system like that doesn't work anymore, but it doesn't mean that you can't increase a patient's access to a primary care provider, to a board certified physician. And really that's what we work to do with this program. Is we want to bring that provider into your home in a meaningful way, while still being respectful of their time, so that they are able to access or be available for a lot of other patients, right? And so I always say that what this does is it adds the third, fourth, and fifth dimension to traditional telehealth. As you know, anybody knows who's used traditional telehealth, it's really limiting. And even the physicians will acknowledge that providing care in a telehealth platform is limiting, right? You don't have any peripheral vision. And so the community paramedic adds that peripheral vision. They actually get to see the entire environment that the patient is living in, and can help identify challenges. You don't get to hear the patient's heart tones. You don't get to hear their lung sounds. You don't get to, touch the patient and actually feel that they're hot to the touch, or that their skin has poor turgor, and maybe they're a little bit dehydrated, or their tongue is furrowed. And I joke about this one a little bit, but also olfactory senses, right? We add smell. We can actually, sometimes that's not a great thing, but it's always good for the patient, because it gives the physician more information to work with, and provides the physician with a much larger picture, so that they can engage with that patient in a safer and more meaningful way. And I just think we add an extra level of safety to the process, and an extra level of value for the patient.
Yeah, I think that is a great point, James. Dr. DeWall, how would you say this has improved support for your behavioral crisis patients?
Yeah, I know we're getting a little tight on time right now, so we'll try to get through these next slides pretty quickly. So we'll hit on them briefly, but if there's questions, please ask them, and we want to leave some time for that. With the behavioral health, we've actually seen it in multiple areas, and there's some expansion that's being looked at in other parts of Colorado to actually utilize it for telebehavioral health. We've just started doing that with mental health providers, much like we use emergency medicine physicians for the telehealth side. And on top of that, we're looking at it in super rural areas with transport times of potentially 3 to 4 hours to a behavioral health facility to more rapidly assess those patients through telebehavioral health and get them to a more appropriate destination, rather than having to sit in a local ER.
Yeah, and you all have a pretty robust mental health assessment program for your paramedics as well, correct?
Correct. Yeah, we've been doing a mental health assessment program with UPass Regional Health Service District for about 5 or 6 years now, with the goal of decreasing downstream healthcare costs, of which with our latest calculations, we're over $4 million of downstream healthcare costs saved by basically being able to divert these patients from an emergency department over to getting them to a behavioral health crisis center or other community partner.
Great, thank you. And James, how do you all financially sustain a program like this?
That's the question, right? If there's no margin, there's no mission. And we can have all the good intentions in the world, but if you can't find a way to pay for it, then it's not going to be sustainable. Grant funding is good for a short period of time, but it doesn't last. And so for us, it was having the conversations with the stakeholders, who has an interest in sustaining this program. And it's, the payers, the insurance companies, Medicare, Medicaid, and just being a constant thorn in their side and sharing the data. That's why it's so important to collect the data so that they understand, hey, this is the money we're saving you. And then also engaging with the private insurance providers and saying, look, man, we've saved you over $4 million in downstream cost savings since we implemented this program. And that's a true number, by the way. And here's how we calculated that. And you're going to lose that if you don't help support the program. And then reaching out to other stakeholders. For us, the Office of Behavioral Health through the state of Colorado saw the value in the behavioral health services that we were offering. And so they fund those operations. And what's great about that is there's no charge to the patient for our behavioral health services, which means it increases access to care and willingness to reach out for help when you need it.
Thank you, James. And as you all take a look at your value achievement and ongoing development of this program, I'd like to ask Dr. DeWall, since implementing this telehealth system using Pulsara, what are some of the biggest benefits and wins for patient care? And did you see any unforeseen benefits?
Yeah, as I said, we track a lot of data, and I think it's really interesting. What we see on average, these are numbers from 2020 into 2022. We have a small gap in our data purely because we tried a different tracking system that wasn't as successful, so we're migrating that data in. But we have 85% of our data within this data set. And what we see is about 17% of patients are found to be taking their medications wrong. We educate them on scene or provide them other resources, work with their primary care doc, etc. 39% of patients receive some sort of prescription from oxygen to Zofran, albuterol, things like that. We do fall risk assessments within the program that about 8% of our patients are positive, and we have mitigation plans with community partners for that. We also look for substance use issues using SBIRT criteria, and about 5% of our patients are positive with that. And we are able to refer them to medication-assisted treatment teams and other teams. And then lastly, which I think is the most profound, is that we have found an unforeseen benefit is with utilizing telehealth for the patients who typically are actually pretty sick, but don't initially want to go to the ER. The paramedics or EMTs try to convince them to go. They know the patient should go. They potentially are septic, etc. And what they find is that with utilizing a telehealth doc and getting a board certified ER doc to say, hey, listen, this is our concern. This is what we potentially would do for you in the ER. We've been able to get about 9% of patients that get telehealth end up in the ER ultimately. The interesting number from our medical student that reviewed this data from the University of Phoenix found that of those patients that get referred to the ER and ultimately decide to go when they otherwise would have been a refusal, 64% of those patients got admitted ultimately into the hospital, and 100% of them had some sort of intervention, diagnostic procedure, etc., in the ER that otherwise could not be done pre-hospital. Now, our average patient walking into the ER, getting admitted to the hospital in our community is about 24%. So the fact that 64% of patients who went to the ER after utilizing telehealth and otherwise would have refused care got admitted tells us that we're providing better care and helping these patients rather than waiting for them to get more sick and utilizing the 911 system in the future.
Thanks, Dr. DeWall. James, on the emergency responder side of things, how has this new system benefited fire and EMS teams? Has this helped improve collaboration and alleviate stress and burnout? And what about risk reduction?
Absolutely. Great question. So burnout is just a byproduct of providers not having the knowledge, skills, abilities, and resources that they need to address the challenges that they've been asked to face, right? We're ordinary people put in extraordinary situations, and we're not dumb, right? I mean, paramedics and EMTs are generally really smart. And so when you go out there and you see the same patient over and over and over again, and you're not able to get them tied in with the right resources because you don't have the right tools in place to make that happen, that creates frustration. And it creates moral injury because you feel like you're contributing to the problem, and you want to be part of the solution, and you feel like you should be part of the solution. So this program provides our providers not only with the tools through Pulsara, which are great, not only with the tools through the physicians, which is great, but also with the additional training and education to be trauma informed in our approaches and make sure that we're providing services in a manner that don't cause secondary trauma to the patient.
Thanks, James. Just wanted to say real quick, since we are at time, we do value everyone's time, and we're going to stay on to continue to talk. There's just 2 more questions for the presenters, and then we do have a few questions that have been submitted that we want to try and cover. So if anyone needs to hop off, we understand. The whole webinar will be available as a recording later. So Dr. DeWall, what is the future? Are there any plans or interest in expanding into other areas based on your experiences so far?
Yeah, I think one of the challenges, as James alluded to earlier with telehealth, is having enough volume to sustain a system as a whole. And typically it's not one system, even larger urban systems. One system's not enough volume to be able to sustain the physician side of it, to have on-call physicians essentially that aren't doing any other clinical practice like our model is. We don't have people doing a bunch of other clinical practice. It's having emergency medicine physicians who are otherwise off solely doing this. So the goal is to try to look at other opportunities to be able to find not only a system that works, which I think we've proven very well, but a system that's long-term sustainable for all of our communities and our areas and our patients. So there's actually currently, it's really fascinating. This is kind of taking off like wildfire, I think, in Colorado. There's discussions of utilizing this within a nurse navigation program. That's a pilot program in the state of Colorado within multiple counties throughout the state that's running through the end of 2023. There's expansion into ET3 programs, as I talked about earlier, in the Western Slope and other parts of Colorado. And there's another opportunity, as I mentioned, with expansion to work collaboratively with telebehavioral health to be able to provide some of the medical clearance aspects, to be able to get patients to the right place at the right time for their behavioral health and substance use disorder crises that are occurring.
Thank you, Dr. DeWall. And my last question is for both of you, but we'll start with James from the agency perspective. What advice would you give to leadership wanting to build a system of care like this for their own city or region?
Yeah, so really I think the biggest thing that was helpful for me as I tried to understand what the needs were in the community was to feel like I was supported by my management and my leadership team. And that comes systemically just through the way you approach on a day-to-day basis your staff, but also if you're going to make someone a champion of a program like this, and I absolutely recommend that you pick one person and make them the champion, and they'll bring the energy that will bring everyone else along. But the most important thing you can do is let that person know that they're not going to get it right the first time. And you know that, and you know that it's going to, there's going to be some stumbling, and you're going to occasionally head down in a direction that doesn't, deliver on the first try. But that's just, that, hey, look, that we figured out one way that it doesn't work, so we're one step closer to figuring out how it is going to work. So creating that space where it's safe to make mistakes, I think is hugely important for bringing any project to fruition. And so I would encourage that. And then also just empower them with ongoing support and make sure that they know that that the organization's supporting where they're headed, and that their work is important, because that is what drives us to do what we do, right?
And I think from a medical direction perspective, you really need a medical director who's heavily involved in your organization. It can't be a signatory medical director. It can't be someone who isn't allotted the time or the ability or the willingness of the agency to work collaboratively. I'm very fortunate with the agencies that I get to work with as a medical director that there's a huge sense of collaboration and working together. There's not a hierarchy of medical directors in charge of this and agencies in charge of that. It's we all work together to come up with the best solutions. And really having a medical director that can understand community needs, that understands the system, understands how it works, and quite frankly, that's comfortable developing new programs and realizing that on average, within EMS systems, it takes 5 to 10 years to get fully functional when you develop programs like this. So we started in 2020. We're still in our infancy of telehealth, and we know that. And we know it takes time, it takes adjustments, it takes collaboration, and it takes buy-in from all of our partners down to from the EMS provider level all the way through to state organizational levels to what the state allows, what the state doesn't allow, depending on how your state or national perspective is set up. So it's really, really important to have a medical director that's involved in all facets of EMS and who is supported by the agency, by their local healthcare systems, and by the regulatory bodies to allow us to be able to do what we do in our area.
Thank you both. All right, so moving into our Q&A, we appreciate all the questions we've received, and we're going to take about 10 minutes to dive into as many as possible. So first question we have, how do you cover areas without cell service and internet access?
And that's a great question. And so if the patient has Wi-Fi internet at their house, then we'll try and connect to their internet. Like Dr. DeWall mentioned, most of the areas that we cover actually do have at least some limited cell phone service with the Cradle Point Wi-Fi networks that we use in our vehicles. But occasionally, very occasionally, we do run into a situation where the patient doesn't have access and there is no access to Wi-Fi services or internet services. And in those cases, we actually have pre-established rendezvous locations, and we'll offer to give the client a ride if they're able to those areas and provide the services in those pre-established safe zones where they can receive care.
That's great. Next question, can EMS bill all insurances or patients for this service call since you're not transporting to the hospital?
So I can hit on the physician side first from what I know from our physician colleagues. They bill insurance basically as a telehealth visit. So they have their standard billing codes and just bill their insurances. So for our EMS agencies, there's no cost to use the physicians at all. It's just it gets billed out to their insurance. What we've seen is we initially offered a pay at the time of service type thing for people who maybe didn't have insurance or wanted to do that. And only 3% of our patients utilized it to the point it wasn't honestly worth continuing. So we've actually not continued that part of the service. We just either bill directly or bill to the insurance company from the physician perspective. And then I'm sure James can speak to the agency perspective.
Yeah, and the answer to that is you can bill anyone, and we do. We bill the insurance companies every single time, and about 1/8 of the time right now they're paying, but that percentage is growing every single day. So literally every day, more and more insurance companies are seeing the value in the services that we provide and paying for it. Medicare fee for service is actually paying for it now under the ET3 model. So if you're one of the participants engaging in ET3, then this qualifies for reimbursement under ET3 as long as you're following the rules. And then I encourage you to reach out to your payers and call them out. If you have a payer that's predominant in your area and you're saving them money through these processes, and if you're engaging in this work, you are saving them money, then call them out on it and ask them why. Why are you not paying to provide this service to your clients when this is a service that they want? And then say, reach out and ask, how can we collaborate and how can we partner together? How can we increase your value as an insurance provider so that your clients and your customers and their employers see the value in sticking with you as an insurance company?
And we've actually initially for our success, we relied on grants to start the program, which we were fortunate with multiple community partners that were willing to step up and see the value in this and kind of kick it off through grants. And we've been successful in that. Some of our colleague agencies actually have worked with their large insurers, as James mentioned, and got them on board and have been very successful with that. Another group, which we actually didn't think about initially, but that's been served very beneficially is motor vehicle collisions, people who don't initially go to the hospital, but then we know utilize the healthcare system because their neck starts hurting, this and that later on. We've been able to offer telehealth to them on the roadside as well, in a safe place off the road, and be able to alleviate those patients having to go to an urgent care emergency department later on when they start getting their pain, because they understand what's going to happen to them over the next 12, 24, 48 hours and how to manage that at home. And we've actually, through the ambulance side and physician side, been able to bill auto insurance for that portion, for the medical portion, which obviously is a huge savings to them compared to an emergency department visit.
Good point. Next question, who does the follow-up? Dr. Dwell mentioned this helps patients navigate their health care, but often the patient does not contact their primary care provider to follow up. Is there a method to communicate with their PCP that this telehealth visit occurred?
So I'll start with this one. James can add on. It depends. So it depends on which area. With our community paramedics, absolutely. They track patients, they follow up, they work very collaboratively with not only our primary care docs, but we refer to specialty clinics. We have setups with cardiology, with orthopedics, with all sorts of OB-GYN, all sorts of groups. So we have great collaborative relationships that what we actually do on scene with community paramedics, we reach out to those providers right away while they're on scene. And we establish literally a time for them to go in for their clinic visit to make sure that is established. And we've been successful because we brought our community partners in from minute one and said, hey, we have this great idea, who's interested? And we've had overwhelming response with this, with our specialty and primary care, that they take the phone call in the middle of their clinic day. Now, if it's overnight, we can't do that. They're not open. We follow up the next day and make sure that care is done. In some of our other areas that they're doing this as the EMT first responder team or stuff like that, or EMT transport team, they don't necessarily do that as much. And we rely that the patient has followed up. Although interestingly, in those communities, initially, they didn't do that. And now even our volunteer EMT transport service, they actually have taken a practice of following up with all of their patients after calls, and they communicate with all of them. So it's really growing that relationship with EMS as part of the healthcare continuum, that is a very important thing to do. And our providers love doing it because they get feedback from the patient on how they're doing, how things went, and everything.
Great. And this next question I feel like is good for some clarification. Someone asked, if I'm not mistaken, someone mentioned that a link was sent to the patient prior to EMS arrival. What is that used for?
You'll give me taking that one, James?
I'm good either way. Yeah, why don't you go ahead and
Okay.
take it?
Yeah, that one. So there's two options. And honestly, as we're looking at expanding this to other areas of the state that are interested in it, there's two ways to do it. One is if you have a provider on scene, which is typically what we're doing right now. It's a 911 response. We respond to that. We see that the patient doesn't want to go to the hospital. I think basically what happens then is we utilize our EMS systems that we have in place, and they initiate the telehealth call. Now, with like the nurse triage program, nurse navigation program, we're looking at the state level for the pilot program, that's different. There are some areas that what'll happen is low acuity calls that come in through a 911 dispatch center will go to a nurse triage line who secondarily reviews it, and it's a specialty trained nurse triage line for this particular purpose. And those ones may not have any EMS response at all for like alpha level calls. So instead, there's a way to push over a patient side of Pulsara that allows the patient to actually log in and connect directly with the telehealth physician. So there's two different ones. Our traditional is EMS on scene, utilizing their platforms, working directly with the doc, having that third and fourth dimension, as James expressed. There is the other option if you want to have a dispatch nurse triage type program that allows physician directly to the patient and allows decreased utilization of EMS response and fire response. That's obviously another option. So there's really both that are available, and it really depends on your community needs and EMS resources.
Great. And we're in the final 2 minutes. So I just want to ask one more question. How easy is grant funding for these programs to be established?
That's a James one.
Yeah. it depends on where you are and what your partnership is with your grant funding partners. What I can say is it does take some work. I mean, that is part of having a director or a leader who's willing and able to do that. Now, when I started with this work, I had no idea how to write a grant. But I had great partners that were willing to take me alongside and teach me how to do it. So I think if you're good at it, if you know how to do it, it probably gets much easier. But in the beginning for me, the learning curve was steep. So if I had a couple of suggestions or recommendations related to the grant funding piece, the first thing I would say is identify who your potential grant funders are. Understand what their funding priorities are, and those are almost always listed on their website. So look at their funding priorities and make sure that your mission aligns with their funding priorities, and then reach out to the grant administrator early on and set up a meeting with them. And that's exactly what they're there for, and they absolutely love doing that. And then tell them what your mission is, what you're looking to do, and how you think your project aligns with their funding priorities. And they're going to come right alongside you and really help you out and provide you with really good ideas and information. And then from there, keep that relationship fresh and strong, and make sure that you do what you said you were going to do. And if you want to make any changes to your funding or what you're going to do with that money, make sure you have that discussion with them and you get permission from them ahead of time, because sometimes projects do drift and change, but you want to make sure that your funding partners know what that is, and they'll really appreciate that. And then make sure they get recognition for the work, for making the work you do possible. Involve them in any sort of press releases that you do. And I absolutely encourage you to do that. Let your community know the value that you bring to the community, but also how important it is to have those funding partners. And that will help sustain additional funding for new projects and new programs later.
Great. Thank you, James. That is all we have for time. Dr. DeWall, would you like to speak real quick and let people know how they can reach out to you?
Absolutely. Thank you, Karen. Thank you to GEMS and Fire Engineering for sponsoring this and having us on here. We are happy to see people reach out. You can email us, James or myself. We work together constantly daily. So if it's not a question one of us can answer, we'll reach out to each other and try to answer as best as we can. And you're always welcome to come visit. Both James and I have open invitations all the time. If you reach out, you have an interest in coming to beautiful Woodland Park, Colorado in the area, and would like to visit us anytime, we can get that set up. We can talk about the medical direction side. We can talk about other stakeholder sides. We can have you ride along with community paramedics, check out the system, check out the technology, what we do. We're happy to do that. So please feel free to reach out anytime. Thank you. And thanks for the opportunity.